All right, good evening, everyone, and thank you for joining us for tonight's Woo You event with the one and only Dr. Mila Brujic. He's going to be discussing rule these out before you diagnose it as dry eye. Next. So I will be your host tonight. My name is Dr. Ariel Sorenzi. So it's my honor to introduce our awesome speaker who we've had on Woo You several times now because he's such a great speaker and certainly an expert in the dry eye field. So Dr. Mila Brujic is a 2002 graduate of the New England College of Optometry. He is a partner of the Premier Vision Group, a 4-location optometric practice in Northwest Ohio. He practices full-scope optometry with an emphasis on ocular disease management of the anterior segment and specialty contact lenses. He is active at all levels of organized optometry and is on the editorial board for a number of optometric publications. He has published over 450 articles and has given over 2,000 lectures, both nationally and internationally, on contemporary topics in eye care. So we're so excited to hear from you, and thank you so much for sharing your knowledge with us tonight. Now go and here's his financial disclosures, and I'll have you take it away from here.
Thank you, Ariel, and thank you all for joining us this evening. First and foremost, I'm so glad that you asked me to give this lecture, this discussion, because this talk, I think, is so timely in a space where we're consumed with so much around dry eye. And I think it's so important clinically that we make sure that as we hear these complaints of dry eye, we don't necessarily jump to that as the diagnosis, and we're ruling out other things that oftentimes masquerade themselves very similarly as dry eye. And the better that we can do that, the better problem solvers will be for our patients. And the better we can do that, the more targeted we can be with our therapies. Now, before we get into the discussion, it is important for me to share my disclosures. I have worked with a number of companies within eye care, and I am fortunate and blessed to be able to work with these companies. And I work with them in a variety of capacities, either speaking, writing, acting in an advisory capacity, or performing research for the companies that are listed. And like I said, I hold the relationship that I have with these companies in high regards. And it truly is something that I view as a true partnership between the clinician on the ground floor, which is myself, and the companies that are creating those technologies that we use. And we'll be talking about many of those this evening. Saying all of that, all the financial relationships have been mitigated throughout the discussion. So when I share things with you here, they're not going to be in a promotional manner. They're going to be very clinically based, scientifically backed, with a lot of information around it. And certainly, if you have any questions after the discussion that don't get answered, Ariel and I have carved out about 5 minutes for question and answers. If things don't get answered, feel free to email me at the email listed here. And I also have that at the end of the discussion as well, too. So again, the reason we're here tonight for 50 minutes of CE, which is the first that you all get, but more importantly, in my mind, is to think about the things that we need to rule out that present very, very similarly to the way that dry eye does in our clinical practices. And the first thing I wanted to go over is something referred to as epithelial basement membrane dystrophy. This goes by several names. It's sometimes referred to as MAP dot fingerprint dystrophy, Cogan's microcystic dystrophy, or anterior basement membrane dystrophy. And oftentimes, the way that we refer to this condition will oftentimes be based on where we were trained and depending on the individuals or the clinicians that we're communicating to. It is interesting when you talk about this, we refer to it as a dystrophy, but there's questions and arguments in the academic space around whether or not it is a true dystrophy, or it just simply may be a degeneration of the tissue over time. We do know that the risk factors are family history, although this is a very, very difficult thing to track genetically. Ocular injuries like abrasions can actually lead to irregularities in the surface of the eye, and ocular surgeries can also cause these as well. For those of you that see patients who've ever had cataract or refractive surgeries, you can see sometimes at the incision regions, you see these areas of negative staining. Basement membrane dystrophy essentially extends abnormally into the corneal epithelium. So what happens is you have this aberrancy or this irregularity in the basement membrane of the epithelium, and it actually elevates itself within the epithelium, causing the total epithelium to be elevated in those regions. And when we place fluorescein on the eye and look at these corneas, to us, they look like there's negative staining. And we would actually assume that the corneal epithelium is actually thickened in those regions, where in fact the exact opposite occurs in those areas. The corneal epithelium actually is reduced in thickness in those regions. And the reason why this is so important to identify with patients is because this can actually lead to recurrent corneal erosions because of the irregularities in the epithelium that are now much more easily caught onto and grabbed by the upper eyelid. It can cause reduced vision in more serious circumstances or more severe circumstances. And interestingly, it can cause fluctuating vision. Now, this fluctuating vision is very different than what we see when we're talking about the dry eye patient. The dry eye patient will have fluctuating vision that will literally fluctuate in between blinks, or they'll feel like they have to just pause and wait and keep their eyes closed and then open them to regain a certain level of normalcy with their vision. Patients with EBMD will oftentimes have fluctuating vision where the vision may be a certain refractive error one day, and then the next day it may be different. And the reason why it's important to identify these individuals is because if you don't, these are the patients that are coming back for several glasses remakes with shifts in the axis and their astigmatism and or shifts in the power profile of their astigmatism. Now, these are two extreme examples, and these are pretty obvious examples of epithelial-based membrane dystrophy. On the right, you can see it in retroillumination, and on the left-hand side, you can just see it with a standard slit lamp evaluation, but you can see the irregularities. You can see some of the clouding around the map patterns. At times, it's much more subtle, but it can still affect the vision. And this has been such a problem solver in my practice. Every single time I have an opportunity to communicate with colleagues in a forum like this, I always share with them the one most important test I feel that we have is fluorescein dye, a rat number 12 filter, and a cobalt blue light setting on our slit lamp. As we're evaluating these patients. And this is an individual who has epithelial-based membrane dystrophy where you can see the frank negative staining that's present here. Interestingly, in this individual, it's actually a little bit difficult to see this on a standard white light assessment. Even with as obvious as this presentation looks here, it's somewhat difficult to see this with just a standard white light. This is another example of an individual or a patient who has EBMD and an associated recurrent corneal erosion. You can actually see where the erosion happened and now where it's attempting to heal again around this edge. Now, I shared with you earlier that the epithelium, although it looks elevated because of the negative staining, the epithelium itself is actually thinned. And here's the proof to demonstrate this. So what you're looking at here is an OCT scan, a cross-sectional cut of a patient with EBMD. So that's what you're looking at here, and you're looking at the vertical cut. In the bottom here, you're looking at the total corneal thickness or total pachymetry scan. And on the bottom right, you're actually looking at the epithelial thickness map. And what you can see here is in this region right here of this patient, it's in what we would consider the normal range in the low to mid 50s. But up here, you can see it's actually much thinner in the 40 to 42 range. And when you look at the color scale, you can see that these blues represent thinner regions of the epithelium. This actually corresponds to the areas that we see on slit lamp evaluation as negative corneal staining, where you can see those definitive map outline edges and patterns. But this is elevated on the slit lamp, but it's elevated because of the combination of the aberrant basement membrane that's folded up underneath the epithelium, and then the thinned epithelium that sits on top of that. But the actual epithelium itself is physically thinned out as shown in the epithelial thickness map. So how do we treat these patients? Well, some of the treatments for these individuals are similar to dry eye patients, but this is someone where we would avoid things like anti-inflammatories or anything else where we would typically think about an inflammatory etiology. So lubrication is usually the first thing that we do if there is discomfort. Consider punctal occlusion because oftentimes these individuals will have a normal tear film, We're just trying to keep what's on the eye there longer because the tear film has a more difficult time spreading over that irregular surface. Ointment in the evening, and considering hyperosmotic agents for those individuals that might have a concurrent recurrent corneal erosion with this would be nice as well. Contact lenses as bandages to improve visual quality, specifically things like higher modulus silicone hydrogel lenses and or scleral lenses work well in these instances. Amniotic membranes for individuals who have repeated recurrent corneal erosions work well. There is data to show that for those patients who have recurrent corneal erosion secondary to EBMD, oral doxycycline actually reduces the amount of events that these individuals have. And usually 50 milligrams twice a day will be fine for those patients. Corneal debridement can actually occur in an attempt to allow the new epithelium that grows over that region in hopes of a more normalized epithelium and basement membrane. And also PTK or phototherapeutic keratectomy is one of the options for these patients, again, in hopes that the new epithelium that will grow over that region will be more normalized. But again, it's a different strategy that we're taking with these patients than we typically do with the dry eye patient. But they'll present oftentimes very similarly. And when you hear fluctuating vision, we oftentimes think, unstable tear film, when in actuality, it might be an unstable tear film because of an irregular corneal surface. Here's another one that oftentimes gets mislabeled as dry eye as well too, and that's floppy eyelid syndrome. Now, we all know what floppy eyelid syndrome is. It's essentially an extensive lid laxity secondary to decreased elastin content in the tarsal plate. So there is this spontaneous aversion or risk of spontaneous aversion of the lid while sleeping. This can cause chronic irritation of the lid, and it's part of the reason why, in my mind, it's critical to avert the lid on every single patient at every single encounter. So again, because of that low elastin level, you can get that spontaneous aversion, and they will come in periodically once or twice a year with acute red eye symptoms, but they oftentimes just have, in general, these uncomfortable eyes. Now, the reason why it's important for us to identify this is because oftentimes these individuals will have obstructive sleep apnea. The literature is clear on this, and it shows between 85 to 99% of patients that present to our office with floppy eyelid syndrome will in fact have obstructive sleep apnea. And if you ask these individuals, a lot of times they'll tell you, oh yeah, I do have sleep apnea. And they'll then tell you, oh yeah, I do use a CPAP. And that's something that they oftentimes don't describe in their history. So it's one of the reasons why it's important to uncover this, because this is part of the way that we determine whether or not these individuals do have obstructive sleep apnea and may be using a CPAP, because that may be the cause of their comfort or ocular comfort issues. This can be associated with keratoconus and also Down syndrome as well. What you can see here, although this is a video of me at the slit lamp and you guys aren't getting the true sense of how loose those lids are, but you see how easy I avert the lower lid and how easily I averted the upper lid as well too. So this is that loose lid that's associated with that floppy eyelid patient. So again, watch how easily this upper eyelid is averted. So it's simple, it's easy. There's no elasticity that's pulling back. One of the things that's interesting, and it's a new tool in our space called the MyVerter. It's actually intended to be utilized for patients where you're doing mybography on them. It provides a controlled way to avert the upper lid and the lower lid while you're taking those measurements or your technician's taking those measurements. But we found it an awesome tool for those patients that think they got something in their eye, but they have those tight eyelids and you can't avert them with just kind of standard techniques. Once you grab a hold of those lashes with the two rubber ends that you get on the MyVerter, it's difficult to not avert that lid. I mean, the patient can even have very sparse lashes along the lid margin and you'll still get a good eversion. One of the other things that you'll see in these patients when you avert the lids is you'll get a sense of the presence or absence of lid wiper epitheliopathy. On the left-hand side, you see the absence of lid wiper epitheliopathy, but you do see the line of marks that's present right here, that small little thin line that separates the anterior keratinized epithelium of the lid from the posterior mucous membrane of the lid. On the right side, you actually see lid wiper epitheliopathy, that staining on the lid wiper region of the eye. You'll also see the presence or absence of papillary responses, specifically things like GPC or giant papillary conjunctivitis. And that will send us in a different direction as well, too, with our dry eye symptomatic patients. So it's important to do this as we're treating these patients, because oftentimes, if these people don't know they have obstructive sleep apnea, or if you ask and they say, yeah, I snore a lot, or my partner says I snore a lot, and I do wake up frequently in the evening, not to go to the bathroom, but because I'm waking up snoring, this is a trigger to refer to physician for further testing. One of the things that we need to be cognizant of is to monitor the optic nerves in these patients. Now, as we identify this and say, all right, now we've at least identified this as the probable cause of the symptoms that the patient's noticing, we now have to treat appropriately. And that's usually ointments in the evening. You can use eye masks in the evening, whether they be more specialized eye masks, like something like an eye seals. Those work really well because they have the rubberized ends on them. A blepharoplasty certainly can be performed for these individuals as well, too. Lacrocerts in the lower fornix work well in the evening because it just keeps lubrication on the eye. Punctal plugs work really well in these patients because it just keeps lubrication on the eye. It's more likely to keep lubrication on the eye in the evening. And there's something referred to as sleep right. Sleep right is actually a medical grade tape that you can put on the eyes to keep them closed in the evening. And it's typically utilized for patients who have incomplete lid seal. Incomplete lid seal describes a situation where a patient will close their eyes gently. And as they close their eyes gently, while we shine a transilluminator in the upper corner of their upper tarsal plate, we'll actually see light emerge from where the upper and lower eyelid meet. And in this instance, for example, you have an inadequate lid seal. This is the sleep tight system for patients. And it's literally medical grade tape that has these small little blue handles on them. So it's easier for patients to peel off in the morning. And it just simply keeps their eyes closed throughout the night so they don't get that exposure. It works great for people who can't actually wear some of those rubber masks, or if they can't sleep with something around their head. All right. So as we progress through the discussion, and things we need to be cognizant of ruling out as we hear these patients talk about dry eye symptoms, and even when we sometimes examine the ocular surface and see things that are consistent with dry eye signs on the surface of the eye, like corneal staining, we need to make sure that we're looking at other conditions that may cause or trigger some of these events to occur. And one of them is thyroid eye disease. And thyroid eye disease can be just like any condition that we manage in our clinical practices, mild, moderate, or severe. And we're going to talk about that in just a few moments here. But I think this is an important time to just go over basic thyroid function. So the thyroid gland is stimulated by thyroid stimulating hormone that's produced by the pituitary gland. The thyroid gland produces thyroxine or thyroid hormone, and alterations in the balance of the hormones can cause problems to arise. Now, when we think about the normal feedback loop that occurs, you have the pituitary gland producing thyroid stimulating hormone. It stimulates the thyroid gland to produce T4, and that actually acts in a negative feedback loop to that same pituitary gland to say, hey, pituitary gland, moderate the amount of TSH that you're actually producing because we have enough in the bloodstream. It's when you get this imbalance that starts occurring that you run into the problems or the issues. So for hyperthyroidism, which is the number one reason that you'll see thyroid eye disease, although it's not the exclusive reason that you'll see thyroid eye disease. You can actually see thyroid eye disease with hypothyroidism as well, too. But in hyperthyroidism, this is usually driven by an autoimmune response where you have antibodies to the receptors on the thyroid gland that are stimulating it to produce thyroxine or thyroid hormone. So you have this high level of thyroxine in the blood, and you have this low level of thyroid stimulating hormone because this is telling the pituitary gland, hey, stop producing TSH, when in actuality, this isn't stimulating the thyroid gland, it's the autoantibodies. There's also hypothyroidism, and there's primary hypothyroidism where the thyroid gland is just simply lethargic. It's not producing enough thyroxine or thyroid hormone, even in the presence of appropriate stimulation from the pituitary gland. And then you have secondary hypothyroidism, where it's caused because of a lack of appropriate pituitary gland activity that's causing low levels of thyroid stimulating hormone, thus leading to low levels of thyroid gland activation. Now, when we're talking about thyroid eye disease, we're talking essentially about the proptosis, the pain, the uncomfortability that occurs in these individuals. But there's two phases of this condition. There's the active phase where patients will come in actively telling you that my eyes just feel sore. Something behind my eyes just feels sore. They'll oftentimes have problems with eye movement, so they'll have pain or discomfort on eye movements. They'll oftentimes see diplopia. And that's what we refer to as the progressive or active phase of the disease. That usually occurs in about 6 months to the first 3 years. And then at some point, it'll transition to the fibrotic phase. And the fibrotic phase is that phase where now you don't have active inflammation, but now you have fibrosis of the tissue in the orbital space. And in doing so, what ends up happening is you start to get some of these long-term manifestations. These are the people that you've been seeing for the last decade who have visible proptosis. They don't want to go through any aggressive surgical procedures like orbital decompression, which usually happens in the fibrotic phase, or even in the progressive phase, they need retrobulbar, or they used to need retrobulbar corticosteroid shots to reduce the inflammation. They just didn't want to go through those things. So they end up with this fibrotic phase where they have this visible long-term proptosis with the manifestations usually of eye dryness or eye discomfort issues. So what's happening is you just simply get this overactivation of the IGF-1 receptor on the orbital fibroblasts. And what this does is it just literally stimulates those orbital fibroblasts to cause or create inflammation. And when that occurs, you get the downstream sequelae of what occurs with thyroid eye disease, which is an increase or an expansion of the tissue in the orbital space. And that actually presses on every part of the orbit, including the nerves, the muscles. But the part that's going to give is the anterior component of the orbit, which is where the eye is, which is why oftentimes these individuals will manifest with proptosis. Now, proptosis can be mild and proptosis can be severe. But one of the key hallmarks to proptosis is something referred to as scleral show, which is something that we need to start being more cognizant of as we're examining these patients. So scleral show, for example, is this right here. We don't expect to see the eyelid above the position of the vertical visible iris diameter. We don't expect it to be below the vertical visible iris diameter. On this patient's left eye, you see it's both. And in this instance, you don't have as much scleral show, but when you look very closely, you see a slight amount of scleral show. And you also see an asymmetry between the two eyes. And you can see the same thing, only a more pronounced response in the individual on the right-hand side. So this patient right here on the left, they will present early on very similarly to the way that a dry eye patient does. Now, here's the good news and the reason why it's important for us to identify these patients. There are now alternative treatments to the traditional corticosteroids, the retrobulbar shots that were done, or the decompression surgery that used to occur in these patients where simply orbital fat was just removed from the orbital space during that fibrotic phase of the thyroid eye disease. Now there's something referred to as teprotumumab, or what's commercially available as Tepezza. This is an infusion, and the way that patients are treated is they get 8 infusions separated by 3-week intervals. And what you can see here is the pivotal clinical trial data results. You'll note that every single time we talk about pivotal data, there's now always 2 studies. And the reason why that is that's direction from the FDA that's told all the companies that have new pharmaceuticals, hey, you have to run the study twice to prove that the results are virtually identical, which is what you can see here. What they're measuring in this study is the percentage of proptosis responders. That is an individual that's responded by a reduction in proptosis of 2.5 millimeters or more than that. And what you can see is in study 1 at the end of the 24 weeks, 71%, and at the end of study 2, 83% met that endpoint. When you take the total amount of proptosis and you just simply average that amount that it's reduced, you can see that it's 3 millimeters in the first study and 3.3 millimeters reduction in proptosis in the second study. And the pictures of these patients through the clinical trials really show it all, where you can see the patient in the placebo group at baseline and then at 24 weeks, and you can see she actually got worse during the study. Whereas these two individuals, you can see how they entered the study, and you can see what they look like 24 weeks later with a marked reduction in proptosis, specifically with the individual in the middle, but also too with the level of visible scleral show. You can see they both demonstrate it up here at the top or above the vertical visible iris diameter between that and the lower portion of the upper lid margin. So there's that white space, and you can see that it's completely gone here. And when you look at coronal cross sections of these patients through in the clinical trials, the proof's really in the pudding, and you see where the mechanism of action occurs. It actually acts on those orbital fibroblasts and causes them to stop becoming these reactive inflammatory cells. Because again, oftentimes the orbital fibroblasts are these naive tissues or these naive cells. And in the presence of thyroid eye disease, they become these inflammatory cells. Well, this just subsides that inflammatory response. And you can see pre-treatment pictures here on the left and post-treatment pictures here on the right. And the two things to note are, one, how white and hyperfluorescent the muscle actually looks on the left versus here. And two, how poorly defined the edges of the muscle are here on the left versus how well defined they are here on the right picture. All right, jumping into the next condition, this is referred to as Kearns-Sayre syndrome. This is certainly something that's not common, but you will see it in your practice lifetime. The thing with this is it affects many body parts, and it usually appears before 20 years of age. It's caused by a mitochondrial DNA abnormality. Remember from our cellular biology that mitochondria has its own specific DNA in addition to the cell's nuclear DNA as well, too. And what it does is causes progressive external ophthalmoplegia. So it causes a paralysis of the extraocular muscle. So these individuals oftentimes don't have good extraocular movement. It causes atosis and a very, very narrow palpebral space. Oftentimes you'll see pigmentary retinopathy in these individuals, but there are other systemic things that occur with these patients: cardiac conduction defects, ataxia, other muscle weaknesses, because it does affect the mitochondria, which is really the energy store in our cells. And the prevalence is 1 to 3 in about 100,000. And the level of severity that you'll see actually changes or is very, very different in different patients. Now, this is a patient with Kearns-Sayre syndrome. And what you can see here is what initially looks like some corneal staining inferiorly. But what this actually is pooling in areas where the cornea has actually thinned out tremendously. And you get a better sense here on the optical section at the slit lamp where that cornea has thinned. So you just get this massive pooling of fluorescein in that region. And when you look at these patients' cornea on OCT cross-section, this being the superior portion, this being the inferior portion, you can see where that thinning occurs. So when we're treating these individuals, really what we want to do is we want to get that ocular surface covered. So ointment in the evening, because these patients oftentimes don't blink well and they don't close their eyes well. Sleep tight is an appropriate treatment for these individuals, or an eye mask in the evening. Blepharoplasty can also happen in these individuals, lacrocerts in the evenings, and certainly punctal occlusion just to maintain the fluid on the surface of the eye works well. Mucus fishing syndrome is another one of these kind of mimic conditions to dryness. And again, this is a cyclical worsening of symptoms, and patients will physically fish mucus out of their eyes, usually from some form of irritant that started it, and then they just never stop doing it. So be cognizant of this when the patient complains of, yeah, I have this long stringy strand that I can pick out of my eye. Ask them to pick it out of their eye in the exam chair, and you'll see oftentimes how aggressive these individuals are with their eyelids. The good news is this is easy to treat. You have to do two things. One, get the mucus out of the eye. And the second thing you do is usually treat them with a topical corticosteroid for about a week, just to get all the irritation away. And usually that's all you need to treat these individuals. What we've started doing with these patients is we've also started treating them with a Rinsada rinse. You're going to see that at the very, very end of the discussion. One of the other things we need to kind of make sure that we're differentiating against when we're seeing somebody come in with symptoms that are similar to dry eye is something referred to as advancing wave-like epitheliopathy. So what this is a wave-like appearance of epithelium that extends from the limbal area into the central cornea. It's believed to be caused by some form of toxic response of the cornea secondary to something that's being introduced to the ocular surface. You're going to see a picture, a clinical picture of what this looks like in just a second, but when we're thinking about differential diagnosis for these patients, we're thinking about things like SLK, limbal stem cell disease, epithelial basement membrane dystrophy. And I'll show you the clinical picture and I'll share with you how you can differentiate against those a little bit more so. So ultimately, to treat these individuals, what we do is remove those substances that we believe to be causing the response. Silver nitrate is a more aggressive form of treatment, which I've personally never used. But when you look at the literature to treat these individuals, this is one of the things that can be done and applied to the limbal region. Every single one of these cases we've had clinically, we've removed what we've perceived to be the inciting agent that's causing this, and every single time it's gone away within a 3-month time period. And there was only one patient that it took a little bit longer for. So this is the clinical picture right here, what it looks like. And you can see it kind of looks like this wave that's extending into the cornea. Now, how you differentiate this from limbal stem cell deficiency is you don't get the typical clouding at the limbal region like you do with early limbal stem cell deficiency, and you don't get the neovascularization that you tend to see there. You differentiate it from SLK because you usually don't see that area of hyperemia or that very, very irritated conjunctiva superior to the cornea. And you differentiate it from epithelial basement membrane dystrophy because of the pattern. It will always extend from that limbal region and come out into the more central cornea. And this is what it looks like here with a white light assessment. And this is what a topography of that exact same patient looks like. And you can see how this irregularity will cause an irregularity on the topography. And these individuals oftentimes will complain about vision. In our practice, we do a lot of anterior segment disease. We do a lot of contact lenses. So every single time I've seen these patients, it's been secondary to some type of contact lens preservative irritant. We've either switched them to daily disposables if the prescription is available in a daily disposable lens, or switched them to a hydrogen peroxide system, and it's caused it to go away every time. This is an example of a patient who was wearing a specialty lens, so she didn't have the option of going into a daily disposable, but you can see how it tends to regress over a 1 to 3 month time period here by simply, again, removing the preservative, which is perceived to be the inciting agent that's causing it. And after 3 months, you can barely see where that region was present. I want to go over this because this is important to understand. And this is microcyst-like corneal epithelial changes. These can be identified at the slit lamp, at a traditional slit lamp evaluation. They're confluent. They can actually happen at the limbal region of the cornea, or they can extend more centrally, and they can be confluent or they can be non-confluent. So separated and very distinct, or they can be all merged together. But the reason why I share this is a common finding in patients using Elahere. Some of you may be wondering, well, what is Elahere? So Elahere is a therapy approved to treat certain patients with advanced ovarian cancer. These are usually females who have been treated with more traditional treatment regimens. Usually what they refer to these females' cancer as is platinum-resistant epithelial ovarian, fallopian tube, or primary peritoneal cancer. So again, this platinum-resistant term you'll hear when you talk to the oncologists. And essentially what this does is it's an antibody drug conjugate. So what does that mean? That means the inciting chemotherapeutic agent that is toxic to the cells or the cancer cells on this ovarian or on the ovary is attached to an antibody that's very specific for receptors on the ovary. So it's very targeted in its mechanism of action. And the goal with doing antibody drug conjugates as a form of chemotherapeutics is to be very targeted in the way that the oncologists are treating these females. The caveat is there's always unexpected consequences. And one of the unexpected consequences with Elahere are these corneal changes that we can potentially see. So there's actually a black box warning, and oncologists actually need to have the females cleared with an optometrist or an ophthalmologist before they start treating. Here's why all of this is important. you may be the limiting factor to these females starting their treatment or their therapeutics. The reason why I share that is if you get a phone call to your office about a woman who's going to start treatment for ovarian cancer and they need to have an eye exam, or using Elahere and needs to have an eye exam first, my recommendation is do a few things. First and foremost, do a full comprehensive eye exam. We've actually started doing inflammatory readings, topographies, and also anterior segment OCTs on these females. Then what you need to do is you need to send a prescription to the pharmacy, and these females will know exactly this regimen, but this is so that everybody here is familiar and knows it. So they use a corticosteroid. In the clinical trials, they use Predforte 6 times a day, starting 1 day before the infusion, and then 3 more days after that. So on days 1 to 4, you use it 6 times a day. Then day 5 to 8, you do it 4 times a day, and then you stop. These females will receive infusions every 3 months for their condition. And we are expected, when we see these individuals, we're expected to see them every 6 weeks. So every other treatment cycle, unless they need to be seen sooner. And this is a form, and if you simply scan this QR code, you can actually go to the Elahere website and get this exact same form. But this is what the oncologists are expecting to find out from us. And this gives you all the information that that oncologist wants to know. They just want to know, is the treatment affecting the cornea? All right. Other things that we need to rule out when we're treating these, or when we're identifying these individuals with dry eye, and that is allergic eye disease. Allergic eye disease, the good news is, and the primary symptom of allergic eye disease is itching, and that's what we see here. Histamine release from a mast cell that's populated with IgE. So again, immunoglobulin E, that's specific for a certain antigen. And when you come in contact with that antigen, you get this massive release of histamine in the system that triggers the nerves to itch, that causes vasodilation to occur, fluid to seep from those delicate conjunctival blood vessels, and it causes the conjunctival swelling that we sometimes see, the redness or the hyperemia, and also the eyelid swelling in these individuals. That's the typical acute allergic condition, and that's usually what we refer to as seasonal, which is, again, as its name implies, seasonally specific, or perennial allergic conjunctivitis, which, as its name implies, it's usually something that's more low grade, but present throughout the year. Then you have these more chronic phases of allergic eye disease, which is vernal keratoconjunctivitis. Be cognizant to be very, very specific about and intentional about looking at the limbal region, in particular in young males who have an aggressive form of what you suspect to be allergic conjunctivitis. Look very closely for those Trantis dots, because oftentimes they're present in the very limbal region, but you have to look at that cornea at a high magnification to sometimes see them at very early stages. Atopic conjunctivitis and keratoconjunctivitis is oftentimes associated with other atopic skin conditions. And then GPC, or giant papillary conjunctivitis, is the one that we typically see with contact lens abuse. Now, if I was to ask you what's the number one complaint that a allergic patient will complain of, most of us will say itching. And I always tell everybody to learn from my mistakes. This happened to me about a decade ago, and I changed my whole process in my practice because of it. We started EHR at the time. It was a new system that we were starting, so we were all engaged in the EHR system that we were using. Patient told me that she had itchy eyes. And I said, I'm going to prescribe you olopatadine 0.7%. I want you to use it once a day. I'll follow up with you in a week to make sure everything's getting better. She comes back in a week, and she tells my technician that her eyes are getting worse. So when I walk into the exam room, I said, Mrs. Smith, your eyes are getting worse. And this is what she did. And everybody look at me for this part very, very closely. Again, learn from my mistakes. She closed her eyes and she said, Dr. B, my eyes are itching like crazy. She closed her eyes and she itched her eyelid skin. That's one of those visits where we do the no charge office visit because of my misdiagnosis, because I didn't listen and look. I listened to the patient, but I didn't look at the patient when she demonstrated the itching. I just assumed the itching was the one that we typically think of as associated with seasonal allergic conjunctivitis, which is usually the one that's associated with that knuckle rub in the corner. There's actually 4 types of itching that are highly specific for 4 different types of conditions. The first is what I just showed you, the lid itching on the skin, and that's usually a dermatitis. The second type of itching is along the lash margin. That's usually a blepharitis, oftentimes Demodex blepharitis. The third type of itching is where you pull the lower lid down and it's a mucus fishing syndrome. The fourth type of itch is hyperspecific for allergic eye disease, and that's the one where you usually want to take the knuckle rub in the corner of the eye. There's a fifth type of itching that's non-specific, and it kind of is one that's more diffuse, and that can be everything that we talked about, including dry eye, including allergic eye disease. And because of that, oftentimes that can present very, very differently. So we typically treat these individuals with topical antihistamine mast cell stabilizing agents, which fortunately are readily available as over-the-counter agents currently. There's a new class of molecules referred to as RASP inhibitors. RASP is an acronym that stands for reactive aldehyde species, and there is a molecule called reproxalap that actually is a RASP inhibitor. Watch this over the next several years because the phase 3 clinical trials on this have actually been completed, and Allergan is now working with the company that actually discovered this molecule and studied it in order to take it through to the finish line. Again, this is a really interesting molecule because it traps aldehyde molecules that are in the system at high levels, and it traps them and it inherently reduces inflammation. So this is a patient who came in for a dry eye evaluation on my schedule, and she said, Dr. B, my eyes are bothering me like crazy. And I said, does one eye bother you more than the other one? Yes, this one does. And the reason why I share this with you is because I think there's power in magnification. I think oftentimes we look at things and we skim things on low magnification at the lid margin, and it's very easily missed. And again, I want to show you the low mag view of this patient, which when you take a quick glance at this on the left-hand side, it's very, very easy to miss that lash. But when I show it to you on the right-hand side, it's very, very easy to see this. So again, the treatment for this is absolutely easy, and it's literally a set of jeweler's forceps because of how fine it is. You can actually see on the left-hand side, I tried to grab it with just a traditional set of blunt end forceps, and I couldn't get it because of how fine it was. So I had to get a fine tip set of jeweler's forceps to actually get or epilate the lash. But this is something where the patient walks out and immediately feels better. But the reason why I say that is you'll incidentally find these on patients during exams, and you'll say, does your eye bother you? And say, no. And you'll see staining from foreign body tracking from the eyelash. And you'll say, you don't feel anything? No, but I can tell my vision was a little bit off. And this is where our senses need to go up a little bit more and investigate a little bit more whether or not there may be a neurotrophic component to this cornea. We know that under normal circumstances that the cornea is innervated by nerve growth factor that's secreted by the nerves that innervate the cornea. And we know that in the absence of appropriate nerve innervation, patients will not feel what they are supposed to feel under normal circumstances. And we refer to this as neurotrophic keratitis. And you can see stage 1, which is this diffuse corneal staining. These are patients that will identify as dry eye, but they lack the symptoms of traditional dry eye. So we'll try and treat them with traditional pharmaceuticals, and we won't really get any type of progression in terms of getting them better. Stage 2 is what we would consider moderate, where there's a persistent epithelial defect, but there's no real risk of any type of corneal perforation or infection yet. And stage 3 is where you see this larger region or area that's affected. Now, the key to all of these patients is they have a lack of appropriate corneal sensitivity. Things that put patients at risk are individuals who have had any type of herpetic infection. Chronic dry eye patients are at risk. We know that just looking at the data that patients who have had dry eye for longer periods of time, their cornea has become less sensitive over time. And that's because inappropriate neural growth factor support of the nerves that are in the corneal tissue. So they become less sensitive and they become less long. So they don't sprout out in the cornea the way that they're supposed to. Contact lens wear can actually be a risk factor for this. Ocular surgeries such as cataract and refractive surgeries, including LASIK, RK, any of the other more advanced, the smile surgeries, penetrating keratoplasties can certainly be a risk factor for this. Topical ophthalmic drug toxicity, especially some of the preservatives that are in these substances, diabetes, any type of vascular events, or that anything that compromises the vascular response can potentially cause this. The good news now is we have an active agent, Synedrimen, that can, when dosed 6 times a day for 8 weeks, can actually help promote healing in these corneas. And again, these are individuals who have had 100% corneal healing after an 8-week time period. So you can see it's about 2/3 of the individuals that were enrolled in the pivotal clinical trials versus about 16% of patients on placebo control. We've actually had some interestingly good success with patients with neuropathic pain that we've placed on Oxervate or Synedrimen. And again, we think because there's some type of issue that's occurring with these patients. So how do you identify the individual who has neuropathic pain? Well, they will always have this cumbersome issue. And when you put proparacaine in their eyes, they oftentimes won't feel any better. That's when you know it's a centralized neuropathic pain. And oftentimes the nerves that feed into the trigeminal nerve are actually fed by the trigeminal nerve. So reconstituting some level of normalcy in the trigeminal nerve itself will actually reduce the neuropathic pain that these individuals experience. So how do you test for corneal sensitivity? Think of the cornea being divided into that standard NEI 5 kind of component chart or pie, with the central, nasal, temporal, superior, inferior, and go towards it with a fine cotton wisp. And again, this is simply what Synedrimen looks like. It's bioidentical to nerve growth factor that we actually see in tissues that are secreted from corneal nerves. So one of the other things I felt it was appropriate to include, because again, when we're thinking about dry eye patients, there are things that can cause dry eye. And one of them is inflammation around the lid margin, specifically things like rosacea or inflammatory mediators and markers that are produced around the ocular surface that can cause meibomian gland dysfunction and these other things that lead to the complaints of dry eye. And certainly photobiomodulation or intense pulse light therapy and low light level therapy are becoming more mainstay in clinical practices because they target those blood vessels and the inflammatory byproducts that they secrete at such a good level. One of the other things we need to rule out is blepharitis, and I want to show you how easy this is to overlook. So on the left-hand side here, you can see this individual where when we look at it clinically, we might say, that's not that bad, blepharitis. When we look at the right-hand side, most of us would probably say, that looks like blepharitis that we might need to do something about. This is the exact same patient on the left and the right. The only difference is I examine them with a high magnification view versus a low magnification view. I want to show you another patient where I did the exact same thing. So this is patient on low mag, which again, I will make the argument that I was taught incorrectly 21.5 years ago to examine the lid margin, because I was taught, look at the lid margin at a low magnification. And that's what I'm doing here. And when you do this, you can certainly see the presence of collarettes, but it's very mild in appearance. I'm going to do one step up on the magnification. And I think now we can see that, okay, if this individual is experiencing dry eye symptoms, we start to understand why that might be the case. When I take it and go 1 mag higher, you can say, whoa, okay, this is something that we do need to be concerned about or be thinking about if the patient's experiencing dry eye symptoms. And when we take it to another level, I don't think anybody would argue that, this shouldn't be treated in the presence of symptoms, in particular when these patients present with symptoms that mimic those dry eye symptoms. The good news is that we have good ways now to treat these patients. Understand the dry eye blepharitis syndrome. If you haven't read this paper, please read this paper. It's one of the most insightful papers put together by Dr. Reinerson and Dr. Perry. And it actually discusses the 4 stages of the dry eye blepharitis syndrome. The first is affecting the lash follicles, where you see initially what's called a volcano sign. You see inflammation in the hair follicles that causes the skin around that lash follicle to elevate itself. It's the step or the stage before you see actual collarettes emerging around the base of the lash. And then you'll see collarettes emerge at the base of the lash. Stage 2 of the dry eye blepharitis syndrome is where then you start to see this biofilm form and move backwards towards the lid margin and the meibomian gland orifice, and that will cause congestion and obstruction, and it will continue moving back on the ocular surface where it will affect the glands of Krauss and Wolfram. And then at stage 4, you start to see the restructuring of the lid margin, where you'll start to see notching in these patients and things like that. Well, we can treat these individuals with microblepharoexfoliation, which was really the standard of care other than antibiotic steroid combinations and or lid scrubs, but we had an active way to treat these patients in office. In addition to that, we've had a recent addition, lotilaner ophthalmic solution 0.2%, or excuse me, 0.25%. And this is a drop that you use twice a day. So one drop twice a day for 6 weeks. Now, the interesting thing in the clinical trials is they used a drop. They didn't rub it into their lash margin after they did that. What I'm advising my patients to do is put a drop in the eye, close the eye, and if there's any excessive drop that's coming out of the eye, just rub it into the lash margin, because that's exactly where we want it to get in, where we want it to get its effect. And we've seen remarkable results with this up to this point. Now, we have 2 minutes left, and I want to share with you a new tool that some of you may be familiar with, others of you may not be familiar with. So this is a new rinsing device. It's referred to as an eyelid retracting irrigation system. The brand name for this, so if you Google it, it's called Rinsada, Rinsada. This was developed by a retina specialist because he was looking for a more controlled way for his technicians to rinse the betadine that was on the eye before he did the injections into the eye, because he found some people came back into the office highly symptomatic because the rinse that was performed just by a standard bottle of saline being rinsed on the surface of the eye, it was technician variable. So he tried to formulate a more controlled way to do this. And what he eventually ended up doing was a study between a standard rinse of a saline versus his system, the Rinsada rinse. So again, he did a little over 40 patients in each of the groups, and this is actually the Rinsada rinse. So this is the device, and you can buy this small end that's a disposable end, and you can put it on any standard syringe, so you can fill it up with normal saline and just do it yourself. We actually purchased this preloaded with saline in the syringe. And then again, you can see the different trajectories of the saline that are actually coming out of the Rinsada end. So one comes directly out of the end, and then the other two come in different directions. And you'll see why that's important in just a moment here. So you can see how it's done. So you put a drop of anesthetic in the eye, you rinse the upper and lower lid on both eyes. And what I'll use is I'll usually use one syringe per eye. So I'll do 5 mLs on the bottom lid, 5 mLs on the upper lid. And what I usually do is I usually have a patient hold a dispensing tray that we normally dispense eyeglasses in. That's usually what we put our minor procedure equipment in when we're doing things in the office. And I'll put a paper towel on the bottom, and we'll just run it along the top, and all the extra fluid will rinse into that dispensing tray, and it won't splash back up at the patient. It'll absorb into that paper towel. I'll jump right to the results here. He actually measured inflammation levels on the surface of the eye after a single rinse of just a standard saline wash, and you can see you get a reduction in the amount of inflammation on the eye measured by MMP9 testing. But when you look at the Rinsada rinse at baseline and then about an hour after the rinse, or excuse me, 3 hours after the rinse, you can see the reduction in inflammation that occurred there. So it's significant compared to baseline and also compared to the standard saline rinse. So again, we've started incorporating this into a lot of the conditions that have inflammatory mediators on the ocular surface, allergic eye disease, dry eye patients that we're starting out with treatment. All these things, we're giving them a Rinsada rinse first and then starting them out with treatment.